So, give me a second. And we are live. Injuries around shoulder and fracture of humerus. So, shoulder instability is head of humerus is not stable in the glenoid. Based on the direction, it can be unidirectional instability, bidirectional instability, or multi-dimensional instability. So mechanically, you require an event of fall on an outstretched hand with the shoulder abducted and externally rotated. It is the most common cause. So classification, it can be anterior dislocation, it can be a posterior dislocation, and laxato erecta, which is inferior dislocation. So anterior dislocation, head of humerus comes out of the glenoid cavity and lies anteriorly. Three subtypes are there. You have pterygoid, subcorticoid, and subclavicular. Wherein the head lies in front of the glenoid, it lies below the coracoid process, which is most common, or it lies below the clavicle. Subclavicular, subglenoid, and preglenoid and subcoracoid. Posterior dislocation, you have head of the humerus comes out of the glenoid cavity and lies posteriorly, and it is seen during fall due to electric shock and epileptic convulsion. And in laxato erecta, inferior dislocation, head comes to lie in the subglenoid position. Head of humerus comes out of the glenoid cavity and lies posteriorly due to electric conversion and subglenoid production. Okay. Pathological changes. Yeah, Burkett's lesion, where there is stripping of glenoid labium and periosteum from the anterior inferior surface of the glenoid and scapular neck. Head will lie in front of the scapular leg, and in severe injuries, there is avulsion of a piece of bone from the inferior glenoid rim. This leads to bony Burkett lesion. So then you have Hill-Sachs lesion, where there is depression on the humeral head in the posterior and posterior lateral quadrant. There is depression on the humeral head, and due to impingement by anterior edge of the glenoid. So impingement of anterior edge of glenoid is there, and depression on the humeral head in the posterior lateral quadrant. So then you have rounding off of anterior glenoid rim. It occurs in chronic cases where the head dislocates rapidly over it. Then you have the Burkett's lesion, which again is stripping of the glenoid labium and periosteum. You have Hill-Sachs lesion, which is depression on the humeral head in the posterior due to impingement of the anterior edge of the glenoid. Then you have eburnated rim of the glenoid, rounding off of the anterior head of the glenoid. So on examination, patient keeps his arm is abducted always. Normal round contour of the shoulder joint is lost, it becomes flattened, and there is fullness below the clavicle due to displaced head. So you have a Dewey's test, which is inability to touch the opposite shoulder. You have Hamilton's ruler test, which is ruler placed laterally on the arm touches acromion and lateral condyne of the humerus simultaneously due to shoulder flattening. So techniques of reduction, you have Kocher's maneuver, which is traction with elbow flexed at right angle, external rotated, abducted, adducted, and internally rotated. You first elbow is flexed at right angle, externally it is rotated, you have to adduct it, then you have to internally rotate it. Then you have Hippocratic maneuver, wherein there is firm pressure and steady pull on the semi-abducted arm. Then the foot is placed in the axilla and head of the humerus is levered back into the position using the foot as a fulcrum. That is Hippocrates maneuver. You apply a firm and steady pull on the semi-abducted arm. Foot will be placed inside the axilla and head of the humerus is levied back into the position using the foot as a fulcrum. So complications, you have early complication and late complications. Early complications, you have injury to axillary nerve injury, and you have late wherein you have paralysis of deltoid muscle, inability to, you cannot abduct the shoulder, small area of anesthesia over the lateral aspect of the shoulder is seen. Okay, and late complications, you have recurrent dislocation. Anatomically the joint is very much unstable, joint. Inadequate healing occurs after first dislocation. Then treatment, you have putty-plat operation where there is a double breasting of subscapularis tendon to prevent external rotation and abduction and to prevent recurrences. Then Burkett's operation is there wherein there is glenoid labrum and capsule are reattached to the glenoid rim. Posterior cricoid process is attached with this muscle. It's osteotomized and fixed to the lower half of the anterior margin of the glenoid. And you have arthroscopic Bankhart's repair. Putty-plat operation, Bankhart's operation, Bristow's operation. So Bankhart's, you have glenoid labrum capsule reattached to the glenoid rim. Bristow's, you have cricoid process with its attached muscle is osteotomized and lower half of the anterior margin of the glenoid it's attached. Then fracture of clavicle. So it is mechanism fall on the shoulder or on an outstretched arm. Pathoanatomy, junction of the middle and outer third of the clavicle is the most common site, and it is usually displaced. Outer fragments displaces medially and downwards and due to gravity and pull by the pectoralis major muscle. Inner fragment displaces upwards due to pull by the sternocleidomastoid muscle. So diagnosis, there is history of trauma, pain, swelling, crepitation. Okay, so treatment, you provide a triangular sling. Active shoulder exercises usually 10 to 14 days after the injury, and figure of 8 bandage if there is displaced fracture, and ORIF if there is neural neurovascular deficit and severely displaced fracture with non-union. This is open reduction, internal fixation. Open reduction, internal fixation. Then complication, early complication, fragment may injure subclavian vein or brachial plexus. Late complication, you have shoulder stiffness, malunion and non-union. Then you have injuries around the elbow, which is caused due to fall on an outstretched hand. Hyperextension at the elbow leads to fracture of the humerus above the condyles. So pathoanatomically, there is a line extending transversely through the distal metaphysis of humerus just above the condyles. So you have various types. First you have extension and then you have flexion. Extension, the distal fragment is extended, tilted backward in relation to proximal fragment, and in flexion, the distal fragment is tilted forwards in relation to proximal fragment. And extension type is more common than flexion type. So diagnosis, you have history of fall followed by pain, swelling, deformity and inability to move the affected elbow. Radiological investigations, your distal fragment may be displaced in the following direction. You have anterior posterior view, and in lateral view you can see it is displaced proximally, laterally or medially, or tilted medially. Lateral view also you can see it can be proximal, dorsal or dorsal shift or dorsal tilt. Shift or tilt medially or laterally, and proximally it can go. Then complication. You have immediate complications which occurs at the time of fracture. Early complication is occurring within first 2 to 3 days, and late occurs weeks to months after the fracture. Then we have immediate complications and early complications and late complications. So immediate complications, you have injury to the brachial artery and injury to the nerve. brachial artery and brachial nerve. Injury is by sharp edge of the proximal end. Hand receives blood from the collateral side and the elbow. Flexor muscles of the forearm may suffer ischemic damage leading to Workman's ischemia. Injury to the nerve, we have median nerve and radial nerve. So Workman's ischemia, it is ischemic injury to the muscles and nerves of flexor compartment of the forearm caused due to occlusion of the brachial artery by supracondylar fracture. Commonly affected muscles are flexor pollicis longa and medial half of digitorum profundus. Okay. Then, muscle ischemia will lead to compartment syndrome diagnosed by severe pain in the forearms and inability to move the fingers. There will be stretch pain, wherein pain in the flexor aspect of the forearms when fingers are extended passively. If you extend the fingers passively, there will be pain. Then, swelling and numbness will be over the fingers, and tenderness will be on pressing the forearm muscles. So, treatment, you provide external splints or bandages that may cause constriction. All external splints and bandages that may cause constriction are removed, and you do fasciotomy. That is the treatment of Workman's ischemia. Then late complication, you have malunion, which is cuboidalus, varus deformity or gunstock deformity. Fracture unites with medial tilt of the distal fragment and internal rotation. Occurs due to failure to achieve good reduction and displacement of the fracture within the plaster. Treatment is French osteotomy. Myositis ossification is ectopic new bone formation around the elbow joint due to massage following the injury. So treatment is excision of the myositic bone with excision arthroplasty. Workman's ischemic contracture is sequel of Workman's ischemia. Ischemic muscles are gradually replaced by fibrous tissue. There is flexion of wrist and fingers. Peripheral nerves are attached, and sensory loss and motor paralysis are in the forearm and arms is seen. Clinically, the features are present which are those of marked atrophy of the forearms, flexion deformity of the wrist and fingers, skin on the forearm and hand is dry and scaly, nails show atropic changes, there is anesthesia of the hand, and Workman's sign is seen. There will be finger extension of the interphalangeal joint possible when the wrist is flexed. However, when the wrist is extended, there is contracted flexor muscle tendons which is stretched, leading to fingers flexion. This is Workman's systemic contracture and Workman's sign. So confirmed deformity is there, and treatment you have to do you can provide splint. First of all, moderate deformity you do sliding operation, and severe deformity carpal tunnel and carpal bone excision. You have to do that. So reduction of supracondylar fracture, first you provide traction, then you do flexion, and then you push with the thumb. In that procedure, in this fracture there is vascular injury to the supracondylar due to supracondylar fracture. So treatment plan for supracondylar fracture with absent pulse is, first you do see that there is a supracondylar fracture, radial pulse will be absent. You do immediate close reduction. If the pulse will retain within 1 hour, you have to maintain in slab for 48 hours, and proper reduction and treatment as any other supracondylar fracture can be done. However, if the pulse does not come, and yet if the capillary circulation is good, you can keep it in slab and keep it under closed supervision. If it improves, then you carry it on as normal. If it deproves, you carry it on as capillary circulation is poor. You explore vessel and internally fix the fracture. Then you have cuboidalus vagus deformity, wherein there is diminished growth at the lateral side of distal humerus epiphysis. Diminished growth of the lateral side of distal humerus epiphysis. So clinical features, you have late ulnar nerve palsy, which is tardy ulnar nerve palsy. You have friction neuritis due to upper ulnar nerve involvement over the medial epicondyle due to elbow flexion and extension. Presents with tingling and numbness in the distribution of ulnar nerve. Treatment, you have mild deformity, no treatment is required. For mild, moderate to severe deformity, you do supracondylar osteotomy, and tardy ulnar nerve palsy, you do anterior transposition of ulnar nerve to prevent friction. This is the cuboidalus varus deformity, where there is increased carrying angle. X-ray of the foramen AP and lateral view showing Montegia fracture dislocation, you have to see that anterior dislocation of the head of humerus is head of radius is shown. Injuries to forearm and wrist. You have Montegia dislocation, which is fracture of upper third of the radius and radial head dislocation caused due to force direct blow on the back of the upper forearm. So it is of two types. You have extension type and flexion type. Extension type is fracture ulna angulates anteriorly. In flexion types, the fracture ulna angulates posteriorly. Radial head dislocates anteriorly, radial head dislocates posteriorly. Treatment, you have to do reduction under general anesthesia and weekly x-ray for initial 3 to 4 weeks. Then if reduction is not possible, you have to do open reduction internal fixation with a plate. Complication, you can have malunion of the forearm and limited elbow and forearm movement. So Montegia is upper third of radius of ulna plus radial head dislocation. Ulna angulates anteriorly. This angulates anteriorly, which is extends, and radial head dislocates anteriorly. Both of them occurs anteriorly and in flexion type posteriorly and posteriorly. But this angulates and this dislocates. Then you have Galeazzi's fracture, which is fracture of lower third of the radius. Lower third radius. Then you have distal radioulnar joint dislocation or subluxation caused fall on an outstretched hand. So in this case displacement, the radius is angulated medially and anteriorly, and distal radioulnar joint will be disrupted. There is dorsal dislocation of distal end of ulna. Treatment, you do open reduction with internal fixation with plates, and it can be malunion, maybe deformity and limited supination and pronation. So this is the Galeazzi fracture dislocation. Normal distal articulating surface of radius will face medially and face vertically, ventrally. Then you have Foley's fracture, which is fracture at distal end of radius at costocalcaneus junction, which is 2 cm from distal articular surface. So cause is fall on outstretched and most common in more than 40 years old female. So relevant anatomy, you have distal articulation surface of radius, faces ventrally and medially. Tip of radial styloid is about 1 cm distal to tip of ulnar styloid. It is more distal. Tip of radius is more distal to tip of ulnar. Pathoanatomy, the fracture runs transversely at corticocalcaneus junction. So following the displacement seen in Colles, you have AP displacement, which is proximal shift, radial shift and radial tilt. Lateral displacement, which is lateral proximal shift, dorsal shift and dorsal tilt. So proximal shift is common in both. There is a radial shift, radial tilt, dorsal shift, dorsal tilt. Then you have dinner fork deformity. Injuries associated with Colles fracture: you have fracture of styloid process of ulna, rupture of ulnar collateral ligament, rupture of triangular cartilage of ulna, rupture of intraosseous right ulnar ligament leading to recurrent ulnar subluxation. Okay, so clinical features: you have pain, swelling, and deformity of the wrist. On examination, there is tenderness and irregularity of the lower end of the radius. Dinner fork deformity is there, and radial styloid process will lie at the same level or a little bit higher than ulnar styloid process. Then complications: you have Sudek's osteodystrophy, you have carpal tunnel syndrome, stiffness of joint will be there. There is finger, shoulder, wrist, and elbow due to lack of exercise. There will be stiffness. And malunion will be the redisplacement of the fracture within the plaster will lead to dinner fork deformity. Then subluxation of the distal radial ulnar joint will be there. Distal radial ulnar joint will be subluxed, and there is a shortening of the radius. Ulnar head will become very much prominent, and treatment is excision of the lower end of the ulna, which is Darac's resection. Darac's resection. And rupture of extensor pollicis longus tender can also be there. So treatment of Colles fracture: undisplaced fracture, you immobilize in a elbow plaster for 6 weeks. Displaced fracture, you do manipulative reduction followed by immobilization in a Colles cast. Colles cast is plaster extending from below the elbow to the metacarpal head, and wrist is maintained in palmar flexion in and ulnar deviation. So you provide traction and counter traction. You correct the dorsal tilt and you correct the radial tilt. First you correct the dorsal tilt, then you correct the radial tilt. Just a second. This was upper third of ulna and radial nerve is Monteggia. UMGR. UMGR. Or maybe MURG. Radio is Monteggia. Radius is Galizzi. Murbe. Here it is upper ulna. It's always UULR. Upper ulna, lower radius, and it is third. Okay. So continuing. You have Smith's fracture, which is reverse of Colles. Distal fragment is displaced vertically and it tilts vertically, whereas here the distal fragment tilts proximal. Mania. Distal fragment tilts vertically and ventrally, whereas it was previously dorsally. Smith is tilting ventrally. Close reduction and plaster cast immobilization for 6 weeks, and complications are similar to Colles. Sudex osteodystrophy, carpal tunnel syndrome, stiff joints, malunion, subluxation of radial ulnar joint, distal radial ulnar joint, and rupture of extensor pollicis tendon. Then you have Barton's fracture, which is intra-articular fracture of distal radius. The fracture extends from articular surface of radius to either its anterior or posterior cortices. So types, you have volar Barton's fracture, which is anterior type, and dorsal Barton's fracture, which is posterior type. So treatment, you do close manipulation and plaster cast. Failure of close reduction, you do open reduction with plates. Then you have scaphoid fracture, which is most commonly occurs in wrist of scaphoid, caused by fall on an outstretched hand. Clinical features, you have pain and swelling over the radial aspect of the wrist, and tenderness in the scaphoid fossa, which is anatomical snuff box. Treatment, you provide immobilization, which is scaphoid cast for 3 to 4 weeks. Fracture may not be visible on initial X-ray. Cases with clinical suspicion is treated with scaphoid cast. It's a cast extending from below the elbow to the metacarpal heads. Includes the thumb up to the interphalangeal joint. Wrist is maintained in a mid dorsiflexion and ulnar deviation, glass holding position. Widely displaced fracture, it is open reduction with special compression screw, Herbert screw. So complications, you have avascular necrosis, delayed and non-union, and wrist osteoarthritis. So fracture of the forearm bones is either with wounds will be there or no wounds will be there. Both bones are fractured and displaced, you do open reduction, internal fixation. If it is undisplaced, you do POP for 6 weeks and you provide a brace. If one bone is fractured, look at the proximal and distal radial ulnar joints. If there is no associated dislocation, you do above elbow plaster cast for 4 weeks and provide a brace. If dislocation is present, you do either Galeazzi or Monteggia fracture and do open. It is either Galeazzi or open Monteggia fracture, and you do open reduction, internal fixation. Brace is a plastic molded support for forearm, with the possibility to mobilize the joint, usually after 4 to 6 weeks of immobilization. Then hand injuries, you have Bennett's dislocation, which is intra-articular fracture of base of the first metacarpal with subluxation or dislocation of the metacarpal caused by lateral force applied on the thumb. Treatment is accurate reduction and restoration. If not reduced accurately, it leads to incongruity of articular surfaces. Then you have mallet finger, which is basketball finger, caused by sudden passive flexion of the distal interphalangeal joint, avulsion of extensor tendon of distal interphalangeal joint at the base of the phalanx can be seen. Examination, you have to do, you can find distal phalanx slide flexion will be there. Treatment is immobilizing the distal phalangeal interphalangeal joint in a hyperextension using aluminum splint or a plastic cast. Then we move on to injuries around the hip. You have posterior dislocation of the hip, which is head of the femur is pushed out of the acetabulum posteriorly. If it is associated with chip of the posterior acetabulum, then it is called a fracture dislocation. So mechanism: the force directed along the shaft of the femur with hip flexed. Hip is flexed, and there is a force along the shaft of the femur. So occupant of the cast car, if they are thrown forwards and the knee strikes the dashboard, there is posterior hip dislocation. This is called as dashboard injury. So clinically, they have features of history of severe trauma, pain, swelling will be there, road traffic accident will be there. So deformity will be there, flexion, adduction, and internally rotated leg. There is shortening of leg, lengthening is seen in anterior dislocation, important, and palpation, you have head of the femur is felt in the gluteal region. So then, radiological features: femoral head is out of the acetabulum, thigh is internally rotated, and lesser trochanter is not seen, and Shenton's line is broken. So lesser trochanter appears prominent in case of fracture of neck of femur. It depends on the lesser trochanter appears prominent fracture of neck of femur. So treatment, you have to do emergency reduction, which is longer the head remains out, the increased chances that it undergoes ischemic necrosis. So technique of close reduction: the patient is anesthetized and he is placed supine on the floor. The assistant will grasp the pelvis firmly, and the surgeon will flex the hip and knee at right angle and exert an axial pull. Once reduced, it is possible to move the hip freely in all directions. This leg is kept in light traction with hip abducted for 3 weeks. After 3 weeks, hip mobilization exercises are started. Open reduction indication is failure of closed reduction, intra-articular loose fragment not allowing accurate reduction, and acetabular fragment if it is very large. So complications: you have injury to the sciatic nerve, you have avascular necrosis of the femoral head, you can be having osteoarthritis, and you have myositis ossificans. You have persistent pain and stiffness of hip, and X-ray you'll find a mass of fluffy new bone around the hip. Injury to the sciatic nerve: sciatic nerve lies behind the posterior wall of the acetabulum. It is damaged by a posterior dislocation of hip. Can also perform Gale's traction. This is the fracture on the neck of femur. Intertrochanteric region it can be there, and neck of femur it can be there. Gale's traction can be provided in children if there is a fracture of femur less than 2 years, indicated from birth to 2 years. Procedure: legs are tied to a overhead beam and hips are kept raised from the leg. Weight of the body provides counter traction and the fracture is reduced. It is continued until sufficient callus is formed, 3 to 6 weeks. Then fractures around neck of femur. We have 2 types of fracture of neck of femur: intracapsular fracture of neck of femur and extracapsular intertrochanteric fracture of neck of femur. So fracture of neck of femur, it will never unite. So intertrochanteric fracture will unite readily because it's located inside a capsule. Okay, it is located inside a capsule. That's why neck of femur, it is very difficult to heal. Intertrochanteric is somehow you can do it off. Neck of femur is inside the capsule, so it's a little bit difficult. Pathoanatomy: it is always a displaced fracture, and distal fragment is externally rotated and proximally it is migrated. Then in intracapsular fracture, capsule of hip joint is attached to the distal fragment, and this capsule prevents extreme rotation and displacement of the distal fragment. Capsule will be there, it prevents extreme rotation and displacement of the distal fragment. Displacement is more marked in trochanteric fracture. Trochanteric fracture is extracapsular fracture, and fracture site is outside the attachment of capsule. There is wide displacement which occurs readily. So it is externally rotates and proximally it is migrated. So classification, you can have anatomical classification, which is proximality of fracture. The more proximal the fracture is, the worse the prognosis. Then subscapular, you have fracture below the head. Transcervical is fracture in the middle of the neck, and basal is fracture at the base of the neck. Scapular, transcervical, and basal. Then you have Powell's classification. It is based on the angle of inclination of fracture in relation to horizontal plane, which is Powell's angle. Fracture are divided into 3 types: type 1, type 2, type 3. The more the angle, the worse the prognosis. Type 3 is worse prognosis. Then you have Garton's classification, which is Based on degree of displacement of fracture, mainly rotational displacement, you have Garden's classification. So if only trabecle is bending, it is type 1. If there is trabecle bending between the head and neck and the neck is broken and displaced, then it is type 2. If all three trabecule are out of alignment, then it's type 3. If acetabular and head trabecule are in alignment between the head and neck, but between the head and neck it is not aligned. So all three is not happening. Here this is happening, but this is not happening. Here there is only bending. Trabecule will be bended and trabecule is broken and displaced. This is also proper. This is also proper. But it is broken plus displaced. So clinical features: you will have a pain in the groin, you will have inability to move the limb, inability to bear weight on the limb, attempted hip movements are very painful, and it is associated with severe spasm. One second. Okay. Examination, there will be external rotation of the leg. Patella will be facing outwards. Shortening of leg will be there. Tenderness will be in the groin. Active straight leg raising is not possible. Then pathological radiological features. You have X-ray of the pelvis with both hips. There is break in the mid cortex of the neck, and external rotation of femur can occur. Lesser trochanter will be appearing more prominent. There is overriding of greater trochanter lying at the level of head of femur. There is break in the trabecular seam and break in Sheraton's line. So management also, yeah. So lesser trochanter is not seen in case of posterior dislocation of the hip. Then management, you have fracture of neck of femur. It's either displaced or undisplaced. In undisplaced, you have a conservative and you can do multiple screws. In displaced, it can be physiologically less than 30 years or physiologically more than 60 years. Less than 60 years, you have to do closed reduction under X-ray control. The reduction is possible and reduction is not possible you have to see. Then if reduction is possible, you have to do multiple screw fixation. If it is not possible, you have to do open reduction and screw fixation. Then if it is physiologically more than 60 years old, you have to do prosthetic replacement, either with a normal hip or with a hip with pre-existing arthritis. It can be. So in an otherwise normal hip, you have to do a hemiarthroplasty, which is AM prosthesis, and with hip with pre-existing arthritis, you have to do total hip replacement. So you can do, okay, McMurray's osteotomy you can do, hemiarthroplasty you can do, and Mayer's procedure you can do. Vascular necrosis also is a complication. Okay, so I'll continue from here and I'll finish off in another episode. So very little is there, some 7 pages, 8 pages, 9 pages. Yeah, okay, you can finish it off, but I'll do it after some time. So yeah, thank you guys for watching my stream. I'll catch you guys in the next one. So yeah.